Laparoscopic Hudson's hysterectomy. This is the case of lady in her 50s with the borderline bilateral ovarian tumor, epithelial ovarian tumor. During the diagnostic hysterectomy, a piece of the tumor was sent to frozen section, and the intraoperative pathology revealed the serous papillary borderline ovarian tumor. On the inspection of the pelvic cavity, we see the bilateral ovarian tumors infiltrating the posterior leaf of the broad ligament and small peritoneal implants affecting the Douglas's pouch peritoneum and the posterior leaf of the broad ligament of the uterus. It was decided to perform the modified laparoscopic Hudson hysterectomy, which includes the hysterectomy, bilateral salpingo-oophorectomy, and the posterior pelvic peritonectomy. The procedure was started from coagulation and cutting of the left round ligament of the uterus, and then the incision of the peritoneum was advanced caudate parallel to the vessels of the left epiligament. For this purpose, we used the bipolar grasper and scissors. Then the incision was advanced caudate to have better access to the left pelvic retroperitoneum. Here we mobilize a bit of sigmoid along the white light of Toth. Then assistant is grasping the epiligament so that showing the situation in the left pelvic sidewall retroperitoneum. The first task we do in this step of the procedure is finding our anatomical landmarks, which are the external blood vessels and the ureter highlighted green in this picture. Once the ureter is found, we proceed the dissection caudate towards the uterine artery. Once the ureter is identified, our task is to detach the ureter from the underlying peritoneum. In this case, it is the posterior leaf of the broad ligament of the uterus. Oncologically speaking, we enter so-called Okabayashi space, which is formed by mesoureter and the inferior hypogastric plexus laterally and mesorectum medially. By means of a grasper and suction tube, we bluntly dissect the Okabayashi space towards the pelvic floor. So that automatically detaching the affected pelvic peritoneum from the underlying anatomical structures. This space is very avascular, and the dissection in between those anatomical structures isn't fast. continue the detachment of the peritoneum. And what is it is partially detached from the ureter, mesoureter, and the hypogastric plexus. We start isolation of the vessels of the IP ligament, coagulating and cutting the peritoneum over those vessels. Here we see the vessels are isolated. So we have the vessels isolated, the ureter isolated, and the nervous structures isolated. So now we can demarcate the peritoneum to be removed. Without any risk of damaging of underlying structures. The incision is carried out across the mesorectal fat and mesorectal fascia. Downwards toward the uterosacral ligament. It is important to keep in mind that this is the peritonectomy and nothing except of the peritoneum to be removed during the surgery. Isolated IP ligament vessels and the uterine artery and veins are coagulated and cut by laparoscopic ligature device. And now we have a better vision of the uterosacral and the Douglas's pouch. And here the ureter and the inferior hypogastric plexus were highlighted. And we obtained a visual control over those structures so that avoiding the bladder dysfunction or urethral damage in postoperative period. And next we do the same on the right side. The round ligament of the uterus is coagulated and cut, and the incision is advanced cephalate in the same fashion as it was done on the left side. The proper traction and counter traction of the structures to be coagulated and cut makes us good enough precision and bloodless dissection. Assistant is grasping the IP ligament and retract it medially and cephalate. And again, we're seeking the anatomical structures that are important for this procedure and for any hysterectomy as well. Those are the external blood vessels and the ureter. Here, the right ureter is identified, and we proceed to coagulate and cut the loose areolar tissue surrounding the ureter to have a good visual control over that structure. And we continue detaching the posterior leaf of the broad ligament with the ureter. And then we're starting the entering into the Okabayashi space. It can be done sharply or bluntly, or in combination of sharp and blunt dissection as we do in this video. Closer to the ureter, we prefer to use the harmonic due to the minimal lateral heat spread from the instrument, and so that minimizing the chance of the ureteral injury, thermal injury of the ureter. The Okabayashi space was developed, and on the right side we do the same. We see the implants, and then we cut the peritoneum over the vessels of the IP ligament, and having all the retroperitoneal structures previously dissected and visualized, we can modify the extent of our pelvic peritonectomy in compliance with the number of disposition of the peritoneal implants. Here we demarcate, I would say we cut in size the pelvic peritoneum, or so-called broad posterior leaf of the broad ligament of the uterus, again alongside the mesorectal fascia and mesorectum, which is preserved. And we do this dissection gradually, and at the same time we're attempting to dissect any anatomical structures attached to the peritoneum to be removed. And again, the incision is advanced caudate towards the right uterosacral and the lateral wall of the rectum, which is the part of the Douglas's pouch peritoneum. And here we see that the peritoneum to be removed is well demarcated. This is the rectum, highlighted pinky. And then we catch the rectum, retract the rectum ventrally and cephalate, and enter into the rectovaginal space under direct vision of the ureter. Our anatomical landmark for this dissection is the posterior wall of the vagina, or so-called tenovilous fascia, which separates the mesorectum and rectum from the vagina. And again, being close to the tubular structure, which change the bipolar to the harmonic scalpel to minimize the risk of the thermal injury of the tubular structure, particularly the rectum in this case. We see the rectum, then the peritoneum of the Douglas's pouch is cut and pulled ventrally. So we're combining the traction, counter traction to obtain the good anatomical planes to the dissection. It is important to have a good control over the rectum to avoid the rectal injury at this step of the procedure. And this part of our surgery is more or less similar to total mesorectal incision that is being done for rectal cancer. And again, we cut the left round ligament and advance the incision of the anterior leaf of the broad ligament of the broad ligament of the uterus towards the vesicovaginal fold, and then towards the contralateral around ligament. Here we notice that there is another tumoral implant on the anterior leaf of the broad ligament, which is being excised together with the pelvic peritoneum in one block. We proceed our incision towards the around ligament, and here we see the implant is being included in the specimen to be removed. Okay. The next step is very standard. We just detach the bladder from the anterior cervix and the anterior vaginal fornix. This is a very typical step for all laparoscopic hysterectomies. You'll find the pubocervical fascia, which is our landmark, and then we detach the detrusor muscle from the anterior vagina across the pubocervical fascia in relatively bloodless cleavage plane. And since this, the incision of the anterior broad ligament modified a bit the standard approach to laparoscopic hysterectomy, we enter a bit closer to the bladder, and here we keep the control over the bladder wall and trying to be closer to the peritoneum to avoid the cystotomy at this step. and the irregular tissue located between the both leaves of the broad ligament is incised. And now we're seeking for branches of the uterine artery. Then we move to the left side again. Here we see the ureter, which is very well identified, and we keep it always under our visual control. So that we proceed towards the uterine vessels. At the same time, detaching the peritoneum of the posterior leaf of the broad ligament of the uterus. Again, closer to the ureter, we shift to harmonic. And now we're seeking for the uterine vessels, which are crossing the ureter. At the same time, detaching the peritoneum from the posterior wall of the uterine cervix, and I would say paracervix. And here you see that the uterine branches of the inferior hypogastric plexus are sacrificed. And it is okay because we need to preserve the bladder branches, but the uterine branches can be sacrificed with no consequences. A good traction counter traction obtains a good access to the important anatomical structures. Now we're dissecting the tissue surrounding the uterine vessels. So here the uterine vessels are identified. We see the ureter highlighted yellow and the uterine vessels highlighted red. And now having a visual control over the all structures of interest, we can proceed with coagulation and cutting and transecting of the uterine vessels, the uterine artery and uterine vein. And at the end, we have all the uterine vessels coagulated and cut, and this part of the vaginal fornix is really ready to be removed. Then we shift to the right side. The situation of the right side is a bit different. We see that here the ureter is a bit attached to the tumor, to the infiltrated posterior leaf of the broad ligament, so that we are trying to isolate the distal ureter to be able to remove the pelvic peritoneum with the tumor in one block without destroying the integrity of the tumor conglomerate located just behind of the uterus. For this purpose, we combine the traction, counter-traction, we will visualize the mesoureter and bluntly and sharply dissect the ureter with the mesoureter off the infiltrated peritoneum of the right portion of the Douglas's pouch, and at the same time dissecting off the tumor and the infiltrated peritoneum from the underlying tissues. Then we proceed towards the bladder. We see the ureter well, and we see how sticky is the peritoneum in this anatomical area. However, the goal is to keep the integrity of the tumor and to remove the whole disease in one block. Once the right ovarian tumor and the surrounding peritoneum is detached, we will move towards the Douglas's pouch peritoneum and detach it from the anterior rectal wall and the mesorectum. Keeping the branches of the right inferior hypogastric plexus under visual control. We proceed our dissection between the mesorectum and the tenovilous fascia, trying to achieve the posterior fornix of the vagina. Once the posterior fornix is achieved, we proceed with the colpotomy. The Clermont-Ferrand uterine manipulator is used. Here you see the ceramic colpotomizer that we use to visualize the vaginal fornices. And then we gradually and circumferentially cut the vagina, having the whole tumor and the posterior pelvic peritoneum in one block. Which is the goal of the Hudson's hysterectomy. Now we move to the right side. We cut the posterior fornix of the vagina. And here we see the vagina lumen is open. We have a good visual control over the rectum. And here we dissect the leftovers of mesorectum so that detaching it from the posterior fornix, and carry out our incision towards the previous incision on the left side. Then we move to the left side again. And the rest part of the vagina is finally cut. And now we can retrieve the whole specimen in one block through the vaginal incision. And the vagina is closed by two resorbable monofilament sutures. One is already performed. This is the second one. And we believe that this is pretty enough to close the vagina in the standard hysterectomy cases. Now we catch the posterior wall with the stump of the uterus sacral, and then we catch the anterior wall incorporating the pubocervical fascia, and the last bite to the posterior wall incorporating the tenovilus fascia. This approach is good to avoid the vaginal prolapse in the future. And here we see the pelvis totally clean of the tumor, clean of the peritoneal implants of the borderline serous ovarian tumor. And thank you very much for your attention.